we are talking about the coagulation disorder. Coagulation disorder in general divided into the congenital and acquired. The congenital forms, which is in the commonest, is hemophilia, Christmas disease, von Willebrand disease, and acquired is disseminated intravascular coagulopathy and liver disease. The hemophilia, or in general, the hemophilia is inherited as X-linked recessive, while other coagulation disorder like von Willebrand disease, other factor deficiency, and even combined deficiency is inherited as autosomal form, including hypofibrinogenemia and dysfibrinogenemia. The acquired forms usually either because of the underproduction of these coagulation factors, like in the liver disease, or there is an increased consumption, like disseminated intravascular coagulopathy, or as an immune, as in acquired hemophilia, what's called acquired hemophilia, or acquired von Willebrand disease, which is commonly occur usually in old patients, while others like acquired factor X deficiency, which can be happened in the amyloid. Still, the drug can be induced coagulopathy like heparin, which is inhibition, as you know, antithrombin deficiency, which causes increased coagulopathy, and inhibition of the synthesis by the warfarin through the antagonism of the vitamin K. So we start with the case, and with the 2-year-old boy presented to the hematology clinic after a recent hospitalization of the excessive bruising and joint swelling in his ankle and elbow joint after fall. The patient family history is noteworthy for the consanguinity of the parents and his brother, who also experienced excessive bleeding, although his diagnosis was uncertain. Initial laboratory tests included the complete was normal, including the platelet. PTT was prolonged in this patient. Normal prothrombin time, fibrinogen activity is normal, and because we found that this PTT is normal, there is a mixing study by mixing 1-to-1 plasma, definitely with the normal pooled plasma, and which show there is a complete correction of the PTT. In another case, a 45-year-old man, a severe bleeding followed about 2 hours after tooth extraction. عمرها 54 سنة. She has bleeding the first time from tooth extraction, and she required hospitalization and transfusion of red blood cell concentrate, so she had severe bleeding. This followed after a few days later by the lower limb swelling, with the pain and even thrombosis was suspected. Earlier extraction as well as 2 spontaneous labor were not complicated by bleeding, so she had negative history. Despite she had surgical history previously, it is negative. The investigation showed prolonged PTT and increased fibrinogen concentration, which is 583 milligram per deciliter, and the bleeding time was 5 minutes and 20 seconds, which is normal. Platelet count was normal. The antibody against the factor VIII, which is an inhibitor, there is an inhibitor which is measured usually by Bethesda units, and there is decreased factor VIII activity to 2%. So we have moderate severity of the decrease of the factor VIII level. Ultrasound and Doppler study of lower limb show muscle hematoma rather than deviate thrombosis. You know that the differential diagnosis of the calf muscle swelling, اللي هو deviant thrombosis, in this case show there is a muscle hematoma rather than deviant thrombosis. فإذا الهيموفيليا is X-linked recessive, usually it is بما أنه X-linked, so the presentation is mainly in male, which is usually can be transmitted the disease, or the female transmitted the disease to the female mainly, and which is mainly carrier, while the boys are normal, and the female usually transmitted the disease to the male. So 50% of these patients or siblings is usually they are hemophilic, while the 50% of the female carrier. Antenatal diagnosis usually by chorionic villi sampling, and there is a similar severity in the family of the disease. ومثل ما قلنا usually the female it is a carrier, so we have mild bleeding unless they have severe trauma or they have surgery. وعلى هذا الأساس قسمت الهيموفيليا قسموها إلى سيفير ومودريت ومايلد. السيفير اللي هو عادة يكون less than factor 8 less than 1%, which lead to the spontaneous bleeding, and moderate the level between 2 to 10%. So usually these patients they present of the bleeding after mild trauma or surgery, and the mild between 10 to 15%. So these patients they bleed only unless they have major trauma or surgery. So the severe type usually presented in the infancy, while the moderate usually is than 2 years, and the mild usually more than 2 years they are presented with the manifestation. These patients are different from other Fowler-Brand disease or other platelet disorders. So these patients they are presented mainly with the joint and muscle bleeding, and these bleeding in the joint usually tend to be recurrent. Once it's occurred, tend to be recurrent, and usually occurs in the same joints, what we call the target joints, and this mainly involve the knee, elbow, ankle, and hip. And the bleeding can be happen in the muscle which leads like calf muscle, which leads to the compartment syndrome, and in the psoas muscle, which can be to the neurological deficit mainly on the femoral nerve. So once we have bleeding on the joints, we have features of the inflammation. So the joint it is hot, swelling, and very painful joint. And because of this recurrent, so a long-term sequelae of the bleeding in these patients, they have synovial hypertrophy, which lead to the cartilaginous destruction and features of osteoarthrosis. مثل ما تشوفون هاي الصورة, there is a joint swelling in the elbow joint, which is inflamed, hot, and swelling. So this is the manifestation of the joint bleeding in this patient. هذا ما يعني بأنه these patient they do not have mucocutaneous bleeding. These patient they have bleeding from the GIT, or they have cutaneous bleeding, or even hematuria. عادة اللاب manifestation, these patients usually they have an increase or prolonged PTT, partial thromboplastin time, and definitely the factor 8 level by the factor assay is low, while other elements like prothrombin time, platelet count, and the bleeding time usually is normal. And usually these patients they have at the time of the presentation they have negative for presence of the inhibitor. So how to treat this patient? As definitely these patients should be avoid trauma, and especially in the severe one, these patients they maybe go to the prophylaxis. So as a treatment with severe type, usually these patients they are replaced by the factor 8, which is either derived from the donor plasma or recombinant factor 8, which is IV infusion given twice daily. Rest إذا كان عندنا joint bleeding, so resting the joints and mobility around, followed by the mobilization and physiotherapy. These patients they need vaccination with hepatitis A and B. And regarding the prophylactic, those patients who they experience, especially those with the severe one, who they are experience a single bleeding episode, so these patients they consider for prophylactic treatment either once weekly, or if you have venous excess, they can go to the twice or 3 times weekly of the prophylactic treatment, which can prevent further bleeding, and we can continue as a prophylaxis in this patient. And in mild bleeding, in those patients who they have mild type of the hemophilia, these patients can be treated with the desmopressin which can be covered minus surgery like tooth extraction or exo. As we said, so we have complication in this patient. واحدة من الcomplication اللي can be happen in this patient will infection, because you know these patients they get fresh frozen plasma cryo, despite at the time being no rule for these factors unless the patient unless we have an emergency, وفي بعض الأحيان once the treatment, because it's not available, we go to the cryoprecipitate. Otherwise, fresh frozen plasma and the cryoprecipitate at the time is omit. So most of the time we have either recombinant, and even those patients who they are plasma derived اللي هو عادة الريسك مالت at the time being الريسك مالت الانفكشن أقل. وجود الانهبيتور 20% of these patients after time they develop inhibitors, وهذا يعني بأنه these patients once they have inhibitors so they are not responding well to the factor 8 replacement. فلذلك أي patient إحنا من عندنا hemophilic patient we go to he should go to the surgery, وخاصة إذا مسوي inhibitor before we should do it inhibitor, because once this patient inhibitor the risk of the bleeding is there and they are not responding to the factor 8. So we need either to give high dose of the factor 8 or give prothrombic complex concentrate of the factor 7. قلنا بما انه these patients they have recurrent bleeding at the joint and destruction of the joint, so these patients they have erythropathy and osteoarthritis and deformity which need later on the orthopedic surgery. الهيموفيليا B اللي هو طبعا تفرق عن الهيموفيليا A. This patient again this is X-linked. عادة it is الانسيدنس مالت الهيموفيليا B it is أو Christmas disease is much lower. الانسيدنس مالتها clinically similar طبعا as presentation to the hemophilia A, وطبعا replacement by the factor 9 rather than factor 8 definitely, which is given once because the half-life of the factor 9 is prolonged rather than this patient. And the risk of the inhibitor in this patient is less than factor 8, so it is less than 1%. ومثل ما تشوفون pedigree or inheritance of the X-link or inheritance of the hemophilia, which is as an X-linked recessive, which is the female which is transmitted mainly the disease to the male. So we have another case, 15 years old adolescent female with a history of the hypermenorrhagia اللي هو عادة يمكن يجوك هذا presentation تجيك excess bleeding since start menarche which is a prolonged heavy, and this lead to the definitely severe anemia, so they presented as easy fatigability and decreased appetite and sometimes some degree of the depression. Previous history she had, looking to other side of the bleeding, the patient she mentioned that she had recurrent epistaxis with some ecchymosis and prolonged bleeding during dental procedures. However, this patient most vulnerable and disease, not necessarily to present multiple site bleeding, and sometimes just menorrhagia can be occur in this patient. Investigation طلعت بأنه hemoglobin 6.5, so we have low hemoglobin which is with the MCV 95 with a synodic ليش MCV 95, so this patient she had iron deficiency provided ليش MCV 95, so this patient she had bleeding MCV, so that can be elevated. ال RBC count low, الريتك مالته 8%, وهذا إذا نسوي له correction again still high, but because this patient they have bleeding so الريتك can be still high. So this patient is still polychromasia, platelet normal, Coombs was negative, and the PTT was prolonged and the bleeding time was prolonged with this patient. So we have vulnerable gland disease. Vulnerable gland is affected male rather than female. It is the commonest bleeding disorder. Usually these patients they have Malta, which is type 1, and which lead to the quantitative defect of the vulnerable gland disease, and other type 2 we have abnormal function, we have a qualitative defect, and type 3 again we have quantitative but it's severe type, which they are similarly presented like hemophilia. مثل ما تعرفون function of vulnerable brand disease is act as a carrier for the factor 8, and at the same time it's act to help to platelet adhesion by binding of the platelet to the glycoprotein 1b to the and binding these platelet to the subendothelium when we have an injury. The inheritance of the vulnerable brands as an autosomal dominant, despite type 2 and type 2 can be inherited as autosomal recessive. In type 2 we have many types, what's it called, type 2A, type 2B, type 2M and type 2N. clinically يختلفوا مثل ما قلنا. clinically these patients they are different from hemophilia بأنه the presentation مالتهم يجون على شكل mucocutaneous bleeding, so they can present as an epistaxis, bruising, recurrent ecchymosis, menorrhagia, GIT bleeding, and sometimes even severe bleeding after trauma or surgery. like الكيس شفناها بأنه these patients they are presented with the prolonged PTT, because definitely مثل ما قلنا لأنه it is carrier for factor 8, prolonged bleeding time, and we go to the investigation, we see that these patient they have decrease in the von Willebrand factor antigen, decrease in the function, sometimes what's called rhistostic cofactor assay, and they need to do factor 8 for this patient, which is low, and the PTT is definitely is normal. So management of these patients, those patients who they have mild bleeding, sometimes local measure or desmopressin or antifibrinolytic agent like tranexamic acid may be useful in mucosal bleeding. In case of the severe like post-surgery or post intervention, sometimes severe persistent bleeding, so we need what we call the factor 8 concentrate. factor 8 concentrate which is plasma derived اللي هو عادة يحتوي على factor 8 ويحتوي على von Willebrand factor, because recombinant factor 8 it doesn't contain factor von Willebrand, so we need plasma derived, usual plasma derived factor 8 اللي هو طبعا بي von Willebrand and factor 8. وناو بالوقت الحاضر أصبح عندنا بما يسمى recombinant von Willebrand factor. So 24 years old female presented to the hospital with the confusion and hypotension, as well as petechiae and purpura over 90% of her body, so she had widespread ecchymosis, and her medical history was significant only for hypothyroidism, hypertension, gout, and hysterectomy. Laboratory data include the following: she had anemia, white blood cell elevated, and the platelet count was low. Prothrombin time was prolonged, 20 seconds, with INR 1.8. PTT again is prolonged. The fibrinogen is a little bit lower border normal, and the culture of the blood specimen yield Neisseria meningitis group. She developed renal failure, and she had large ischemic ulcer on both her lower extremity, and the suspicion of the DIC was spotted. So what the DIC? The DIC, so it is a hypercoagulable state which is thrombohemorrhagic. So we have a thrombus, and at the same time we have hemorrhage. So these patients they characterized by so we have, as we said, there is hypercoagulable state. So there is a systemic activation of the coagulation factor through suppression of the through expression of the intrinsic factor from the endothelial cell, or there is procoagulant activation which lead to the widespread thrombosis, and at the same time there is consumption of the platelet and fibrinogen which causes bleeding in this patient. At the same time, there is a lysis of the fibrinogen which lead to the formation of the fibrin degradation product, because as we said there is hypercoagulable state, فإذا الفبرينوليتيك سيستم راح يتحرك عندنا، وهذا الاكسسيف فبرينوليتيك سيستم بنفس الوقت راح يسوي لنا راح يتحرر لنا الناتج اللي هو فبرين ديجريديشن برودكت او واتس كولد دي دايمر، اللي هو طبعا واحده من الانفستيجيشن نستعملها بالدي اي سي. نعرف الكوزز بأنهم مالت الدي اي سي هو الموست كومن از انفكشن، والانفكشن يمكن يكون mainly by the gram negative organism، يمكن يكون الجرام بوزيتيف، يمكن يكون parasitic. Still we have fungal infection can be caused but it's mainly gram negative. The second most common cause اللي هو trauma. The third common cause اللي هو obstetric history either because of the abruption of the placenta or amniotic fluid embolism or because of the preeclampsia. Severe liver failure, which can mimic DIC, malignancy, and extensive tissue destruction like pancreatitis or burns, and sometimes by the toxin or the immunological cause like transfusion incompatibility, or it's called ABO incompatibility, or by the toxin, as we say, the snake bite. Clinically, so these patients, they presented usually they are bleeding. Bleeding يكون from the site of the surgery, extensive ecchymosis, epistaxis, GIT bleeding. So we have bleeding from anywhere, and at the same time we have thrombosis, and these patients, because of thrombosis, this lead to the micro and macrovascular thrombosis, which lead to the multiple organ damage, and this include thrombosis may go to the brain, causes stroke, and it may go to the lung, causes vehicular shortness of breath and hemoptysis. Because of the pulmonary hemorrhage or pulmonary embolism, it's go to the renal. So these patients, they can presented as hematuria, or they can present with the acute renal shutdown, or it can be to go to the cardiac, which causes coronary artery syndrome. So the thrombus, it's go everywhere, and it's can be go to the limb, which can be causes ischemia and finger gangrene. Diagnose, we should have anemia, which is micro angiopathic hemolytic anemia. This means that these patients, they have presence of the fragmented RBC, presence of the hemolysis, and these patients, they have at the same time, حتى نفرق عن TTP, these patients, they have an increase of the prothrombin time and pressure, thrombosplastin time, fibrinogen in decrease, but sometimes this is an acute phase reactant. Like this case فشفناها في انه it is rather than it is normal rather than it is abnormal. However, we have decreased fibrinogen and increased bilirubin, and this is because of the excess destruction of the RBC, because of this widespread thrombi in different site, decreased platelet because of the increased consumption, and the most specific case to increase in D-dimer, or what's called fibrin degradation product. So how to manage this patient? We should treat the underlying cause. If we have an infection, we should treat an infection. If we have obstetric cause, we go to the to the labor, and like in eclampsia, or in case of the abruption of the placenta. And we should deal with the acidosis, dehydration, البيشنت جاك رينال مثل ما قلنا multi organ dysfunction, renal failure, hypoxia. Definitely these patients, if they are bleeding, these patients, they need fresh frozen plasma, 15 to 30 ml per kg, or cryoprecipitate platelet طبعا. Though these patients usually they are presented with the moderate reduced platelet. So platelet transfusion, if the patient less than 50,000 وعنده bleeding فنعطيه، أو إذا كان ما عنده bleeding بننزل البليتلت مالته ل10 ل 20. ف these patient they need replacement with the platelet transfusion. هيبارين، طبعا الهيبارين إذا البيشنت عندك active thrombosis والبيشنت عندك no more bleeding يمكن تعطيه هيبارين. وطبعا الهيبارين إذا كان عندك إذا كان عندك ثرومبوسيس، جاك المريض عندك سكين اسكيميا، أو جاك عندك ثرومبوسيس جاك اسكيميا باللور لم، فالهيبارين طبعا، والهيبارين نعطي lower dose بنعطي continuous infusion. So heparin prophylactic dose to treat established thrombosis, and this is this is skim limb ischemia. This because of the thrombosis of the lower limb. we have another خلصنا يعني another acquired cause اللي هو liver disease. طبعا liver disease هنا الكوز مو بس because of the decreased synthesis of the coagulation factor بالحقيقة there is decreased clearance of the plasminogen activator. المشكلة الثانية بأن هذول patient they have hypersepnism and decreased platelet, they have decrease in the vitamin K production خاصة أو vitamin K absorption خاصة هذول جماعة الكوليستاتيك jaundice. وطبعا هذول البيشنت they are presented with the prolonged PT and prolonged PTT. So treatment in these patients, once they have bleeding, they need to place the fresh frozen plasma. If the platelets severely reduced, we give them the platelet and vitamin K replacement, especially those underlying liver disease that can cholestatic jaundice rather than because of the hepatocellular. Renal failure, it can be lead to the bleeding, and again this is because of the uremia, which lead to the platelet dysfunction, and these patients they present with the mucocutaneous bleeding, meningitis bleeding, and these patients they have presented with the anemia, and sometimes even they have usually they have normal platelet count, but sometimes they have decreased platelet إذا كانت الrenal failure طبعا with underlying cause like the QS. And these patients definitely the treatment هو dialysis. Sometimes we need a platelet إذا كانت platelet low, but most of the time we need a cryo precipitate because the defect here is not in the platelet وإنما هو defect defect in the platelet adhesion to the bone. ولذلك هذول يستفادون من الكرايو rather than platelet transfusion. فيتامين كي deficiency مثل ما تعرفون بأنه موجود عندك بالجرين فيجيتابل بالانتستينال فلورا اللي هو أكو many causes يمكن because of the decrease intake أو because of the malabsorption أو في بعض الأحيان مثل ما قلنا biliary obstruction أو because of long use of antibiotics can lead to the vitamin K deficiency. Clinically these patients they have prolonged PT-PTT, so replacement by the vitamin K, which is given mainly IV rather than IM, given infusion for 10 minutes for 3 days to and treatment of the underlying cause. And this is the summary of this lecture, and thank you very much for your listening.